Hello, my name is Philip Choi. I'm a clinical associate professor of medicine and neurology at NYU Grossman School of Medicine. I'm the director of the Chronic Respiratory Failure and Home Ventilation Program here. And today I'm going to be speaking on decoding ventilator data downloads, which is overall a pretty complex topic, but I'm hoping that after this talk that you'll have a little bit of an insight as to how to systematically go through interpreting data downloads from non-invasive ventilators. And so the goals of the lecture are going to be threefold. One is to recognize the standard information found on data downloads. I think a lot of times it can be somewhat overwhelming and intimidating for practitioners, particularly when they're getting started in this field. So I just want to go over some of the basic data that's found on a data download. And then I think it's important to create a systematic approach to interpreting ventilator data downloads. It's very complex, and so unless you have a systematized approach, sometimes it can feel like solving a puzzle that's just a little too complex. So I want to give you some practical tools as to how you might approach this. And then we'll talk a little bit about recognizing common patterns that require ventilator troubleshooting. So again, this is going beyond just looking at simple things like compliance, hours of usage, and what pressures they're set on, but actually being able to interpret the data so that you can troubleshoot to maximize synchrony and ventilation. So when we think about the data downloads, it's really important to know that the technology has really progressed over the last decade or so. And so most non-invasive ventilation devices have remote monitoring platforms, now oftentimes connected through some sort of cloud system. It used to be back in the days that we would have to download all the data from SD cards, but now everything is remote and we should be able to get data relatively easily. But it's important to actually have access to the various remote platforms. That's really the key to high quality outpatient management of non-invasive ventilation. So as you're entering into this field, it's really important to understand that there are different monitoring platforms and try as hard as you can to try to get access to these platforms. And each one has its own proprietary platform that they use. So Respironics has a system called Care Orchestrator, ResMed has a system called AirView, Breas has a system called Everywhere, React Health, which makes the vPro or the Voxen, has React Health Connect, Movair, which makes the Louisa, has Prisma Cloud. So it's very important to try to get access to all of these if you can. So again, from these data downloads, there's a lot of robust information that may slightly vary by device. So overall, the devices will give you a lot of the same information, but depending on the software, you may get little pieces of information that may be a little bit different from vent to vent. So one of the things that all of the vents will give you is the hours of use. So this is going to be very important for not only clinical management, but also for insurance coverage. In the United States, some of the more simple devices called the respiratory assist devices actually do have specific insurance requirements. So this is going to be important to document. But more than that, you really want to get a sense of whether the patients are using the device, and if they're not, that will help pinpoint some of the reasons why. So again, if they're using it many hours during the day, that's great, but if not, you really want to delve into why that may not be the case. So some of the ventilators will give you an apnea-hypopnea index or an AHI, and this may be a marker of residual upper airway obstruction. Again, not all the ventilators have this data, but if they do, it gives you a sign as to whether obstructive events are being well controlled. So all of the ventilators will give you a leak number. So it's really important to pay attention to whether this is a total leak, which is including the leak built into the mask, or if it's the unintentional leak, because these numbers will differ and you have to really interpret it in the correct way. These data downloads will give you average pressures. So if you are using volume assured pressure support modes, it will give you average delivered EPAP. So if you have an auto EPAP mode, that will fluctuate. And so you get a sense of what that average EPAP is through the night. And then it will also give you the average IPAP that's delivered. So again, if you're using a fixed bilevel, these will be obviously fixed. but in volume assured pressure support modes, these will vary, and so it's really important to understand what those average numbers are throughout the night. So the data downloads will also give you an exhaled volume. So it's important to know that when we're using passive circuits, these aren't measured volumes, these are calculated. And it's important to know that if you are using, whether you're using a volume assured pressure support mode or fixed bilevel, it's helpful information to know what that exhaled volume is. So if you are in VAPS, you can determine whether or not the exhaled volume is actually meeting your targets. Whereas if you're in a fixed bilevel mode, you at least know what type of tidal volume delivery that you're achieving on those settings. So the data will also give you the breath rate. So this is the average breaths per minute. So for patients with spontaneous bilevel, this will give you a sense of what their breathing pattern is. Even if they do have a backup rate, you do want to know whether or not they're breathing close to that or whether they're breathing well above that. So most of the ventilators will give you either an I to E ratio or a TI to T total. So that's the percentage of the time in inspiration. And this can really give you a sense of whether there's any issues with potentially synchrony, but it also helps you troubleshoot whether you need to make any setting changes that are a little bit more complex than just changing the IPAP or the EPAP. And then again, many of the ventilators will give you the percent triggered breaths. So this is the percentage of the breaths that are patient triggered. So if you have a spontaneous mode, this is obviously going to be 100%. Whereas if you have a backup rate, this will determine, this will vary based on how often they're initiating the breath versus how often the machine is triggering the breath. And so for these data downloads, the data can be presented as averages over a fixed period of time. So you can see this example where you're getting a fixed time period. This looks like it was about 32 days. And then you get a sense of what those averages are during that time period. So the average usage, average PEEP, average tidal volume, average leak. Whereas on the non-invasive ventilators, or these ventilators in general, the devices can now present more detailed granular data throughout the night. Actually, an example where I've clicked on one specific night and I want to see exactly what's happening through that night. So this is a patient who's on a volume assured pressure support mode. You can see that that EPAP is fixed throughout the night, but then you can see that the pressure actually changes. So actually having this type of granular data is really just much more nuanced and much more complex than just seeing the averages, because you might have a patient where the averages seem okay, but then you look through the night and there's a lot of variability. So that may give you some sense as to whether you need to make any changes, and really more detailed than what you can get from just looking at the average data. And this is really found on more of the modern ventilators and the more modern algorithms, as opposed to some of the more simple BiPAP machines. So as I mentioned, it's really important to have a systematic approach to really decoding these data downloads. And again, this isn't necessarily the right answer, but it's the way that I kind of approach any patient who's on non-invasive ventilation. So I think the first conceptual idea is to understand the mode of ventilation that you're using. And so this is a separate lecture in and of itself, but think about whether the patient is in spontaneous BiPAP, whether they're on BiPAP with an ST mode, whether they're in a fixed pressure control mode where you have a fixed I time, whether they're in a volume assured pressure support, or whether they're in a volume assured pressure support with auto EPAP. Because unless you start by understanding the mode of ventilation, it's going to really be hard to understand how to both interpret the data, but then also how to troubleshoot. So once you've looked at the mode and understand that mode of ventilation, the next step is to actually look at the settings. And this provides a framework for interpreting the output. So this is what you want the patient to achieve, or what you want the machine to deliver, and then the output is really what the machine is actually delivering. And so this is going to be the way to interpret the way that the machine and the patient are interacting. So once you have a sense of what the mode is and what those settings are, then the next step is to really look at the leak. If the leak is uncontrolled, really all the other output data will not be reliable, particularly in volume assured pressure support modes. If the leak is uncontrolled, then even interpreting the tidal volume data is really unreliable. And so it's really important to understand, is the leak controlled? Next, I would say look at the exhaled volume. This is specifically if you're looking at volume assured pressure support modes, you want to know whether the exhaled volume matches your target. And if not, you must troubleshoot the reason why, and there are multiple different reasons why this may not be the case. Then you can look at the average pressures, and you want to compare to the pressure ranges set in your volume assured pressure support modes. So if you're setting the range really tight, your delivery may max out, or you want to see if whether that minimum inspiratory pressure is really high. Maybe they're always reaching that minimum, and that may affect your tidal volume delivery. Then I would say look at your breath rate and your percent triggered breaths. And you can look at those together because they are always kind of in relation to each other. This will give you insights into the general breathing patterns, and it'll also give you a sense of whether that respiratory rate is set appropriately, if there is a backup rate set. And then the I to E ratio, or the TI to T total, will give you insights into whether the natural inspiratory time is appropriate or whether that may need to be changed. So when you're looking at your data downloads, it's important to first think through systematically how you might actually address each of the parts that I've talked about on the previous slide. So let me first talk about the leak. So when you're thinking about the leak, it's first important to determine whether it is the total leak or the unintentional leak that you're looking at, because every ventilator might give you a little bit of a different piece of data. Some of them will give you both, some of them will give you one. So it's important to know how you're interpreting that data and what it means. So really when we're thinking about leak, we really want to make sure that we're minimizing unintentional leak. And this is the leak that is not built into the mask. And so some of the questions to be asking is, one, does the patient put the mask on correctly? So I think some of the times we make these assumptions that patients actually know how to use the mask, but sometimes, particularly if they're weak, they may be using one hand and it may not be positioned correctly. For some patients, they might think that the mask has to actually fit under the chin, which will create a larger leak. So I think first, make sure that the patient is putting on the mask correctly, and this is oftentimes done in the clinic where you actually ask them to put on the mask themselves. And if not, then you can troubleshoot that and teach them how to correctly put it on. One of the bigger problems ends up being, is the mask sized appropriately? So oftentimes, if the mask is either too small or too large, the leak will be really hard to control. And so it's important to make sure that they have the appropriately sized mask and also the right model of mask for their face shape. So, one of the challenges for men is sometimes that facial hair might prevent a good seal. Oftentimes people are really kind of wedded to their facial hair, and so they may not be as willing to make all the sacrifices. But if that does seem to be a problem, at least discussing it with the patient as to whether there may be ways to either to trim a beard or potentially to shave it all off if it really becomes a problem. But again, try to maximize the seal by making those sacrifices. And then one of the problems ends up being claustrophobia for a lot of patients when using a full face mask. And so some patients really will only tolerate a nasal interface, and it may be more comfortable for them. So if the patient is using a nasal interface and during the middle of the night you notice that there's a high leak intermittently, that may be a sign of leak out the mouth. In those cases, a chin strap can sometimes be helpful, or if it's very severe and you're having trouble with ventilation, then you may discuss switching to a full face interface. So I'm going to move into exhaled volumes, and this is an important topic, and one of the more complex topics, I think, because it's not as simple as just increasing the IPAP. So I always show this schematic when I'm discussing tidal volume delivery in non-invasive ventilation or any kind of pressure mode of ventilation. It's very important to know that tidal volume delivery is going to be proportional to the area under the pressure time curve. And so as you can see, there are different components of this that can really affect tidal volume delivery. I think oftentimes in mechanical ventilation, we think about really that difference between the IPAP and the EPAP, and that is one of the factors that affects tidal volume delivery, but so does inspiratory time, the time at the inspiratory pressure, the peak inspiratory pressure, which is affected by your rise time. And then you also have to understand how breaths are cycled in different modes, and because that will affect your inspiratory time. So at least conceptually understanding this diagram is really important to understand how to troubleshoot exhale volume on your data downloads. And so one of the questions to ask is, does the exhaled volume match the target? So this is particularly important in VAPs, but even if you're using a fixed bilevel, you should have in your mind what type of tidal volume you may want to deliver in order to improve ventilation. So whether it's an actual target volume that you've set in VAPS modes, or it's just a general idea of what the tidal volume should be, you really want to make sure that the exhale volume is meeting your general targets. And so there are common reasons for why the tidal volume will be decreased and not quite at your target. So as I mentioned before, if your leak is too high, one, the exhaled volume reading might not be accurate, but also this will affect the delivery of air into the lungs, particularly if you're in a fixed bilevel mode where there's no leak compensation. And so if the leak is intermittently high, that may lead to a decreased exhaled volume, or an exhaled volume less than what you would expect given the patient's airway resistance and their lung compliance. So one of the other things is that the inspiratory pressure maximum is set too low, or if you're in fixed bilevel, that you're just setting your inspiratory pressure too low. So this may limit the tidal volume delivery, particularly for patients with a very stiff chest wall or very stiff lungs. One is if the rise time is too slow. So the rise time is how quickly the breath will go from your expiratory pressure to your peak inspiratory pressure. So that if that is set very slow, then you're going to spend less time at your peak inspiratory pressure, which will change that area under that curve and deliver a tidal volume that may be less than ideal. The other is if the inspiratory time is too short. So again, this is really important to understand the mode of ventilation. If you're in a mode where the machine triggered breaths or the patient triggered breaths are time cycled, and you're getting that set inspiratory time, then it might be easy to change that. Whereas if you have patient-triggered breaths that are flow cycled, where the patient's really dictating the inspiratory time, you'll have to troubleshoot it based on what mode you're in. And the other thing to really keep in mind, which is not always super intuitive for everyone, is that residual obstructive events, upper airway obstruction, meaning may really limit the tidal volume delivery despite high inspiratory pressures. And so this may reflect in a high AHI, and so rather than just changing the peak inspiratory pressure in those settings, you may want to actually adjust the expiratory pressure as well. So I'm going to move on to average pressures. And so this is a relatively simple concept. It's going to just tell you what that average pressure delivery is. And so if you are in a volume assured pressure support mode, you really want to determine whether or not the average delivered pressure is within your set ranges. So if the pressures are reaching the max EPAP or the max IPAP, you may consider increasing those max ranges, thinking that if it's hitting the max, that may mean that both of those are limiting the breath delivery. On the flip side, if the pressures are at the minimum IPAP, you actually want to see whether the volumes are exceeding your target. So that may be the case where you set that minimum IPAP too high, and actually that your target volumes may be much bigger than, or the exhaled volume may be actually much bigger than what your target is. So always look at both. So I think a lot of times we worry about limiting tidal volume, but think about the ways that the average pressures or the pressure ranges may determine whether the tidal volume may also be too big. So when you're thinking about the breath rate and the percent triggered breaths, this is, again, measuring what the average breath rate is throughout the night or in a given day. And so this is important to interpret along with your exhaled volume to determine the pattern of breathing. So I worry about this a lot in neuromuscular patients. If I see a relatively high breath rate and a relatively low exhaled volume, that really indicates a rapid shallow breathing pattern. So it's important to look at those in the context of each other, because that really can help determine whether or not you either need to change the mode or some of these more nuanced settings may need to be adjusted. And then for percent triggered breaths, this is really important to think about in an ST mode, because if you have a high percentage of triggered breaths, this means that the distribution is really going to favor flow cycled breaths as opposed to time cycled breaths. Whereas if in ST mode that number is very low, that means that most of the breaths are going to be time cycled. And so there is this thought in neuromuscular patients that they may benefit from a lower percentage of patient triggered breaths to reduce work of breathing. Again, this isn't necessarily hard and fast rules or data, but certainly there is this idea that if they're triggering a lot, that may increase their work of breathing through the night. But regardless, it gives you some data as to how much they're triggering, but because in ST modes, the cycling parameters are different based on whether the patient triggers or the machine triggers. These are very important concepts to keep in mind and data to look at when you're interpreting the data, particularly in spontaneous time modes. So when you're looking at the I/E ratio or the TI to T total, this tells you a little bit about what their breathing pattern is as well. So again, you're looking at the respiratory rate, but then you're also looking at this I/E ratio or the TI to T total. So the first thing to really think about as you're thinking about these numbers is to first consider the underlying physiology of each patient. So one thing to ask yourself is there significant airway obstruction? So does the patient have bad COPD, bad asthma, bad airway obstruction? In this case, you may consider trying to target a slightly longer expiratory time. So in this case, your I/E ratio may be closer to 1 to 3, depending on how obstructed they are. Whereas for neuromuscular or restrictive thoracic disorders, I may aim for an I/E ratio that's closer to 1 to 2 or even 1 to 1, depending on what their lung mechanics are. And this would translate into a TI to T total of about 35 to 45%. So it's really important to think about each individual patient in front of you and what the natural physiology may be. And then you have to then troubleshoot by knowing what mode you're in. So again, this seems very complex, but if you go back to the fundamentals of mechanical ventilation, that will really help understanding how do you troubleshoot these I/E ratios or TI to T total. So if you're in a pressure control mode, one where you get a set inspiratory time for every single breath, whether machine or patient triggered, then you can adjust the inspiratory time accordingly. So if you have a neuromuscular patient in pressure control modes and their I/E ratio is 1 to 3, I might just increase their inspiratory time to try to get to that 1 to 2 or closer to 1 to 1 ratio. In ST modes, though, you have to understand first the number of percent triggered breaths, because if that is closer to 80, 90, 100%, then changing that inspiratory time won't make a difference. Whereas if it's a lower number, then changing that inspiratory time may actually make a big difference in terms of that average I/E ratio. There are new modes with a TI min and max setting as well. So this is either on the Astral, where you just have a TI min and max, or on newer ventilators, including the Trilogy Evo or the Breas Vivo 45 LS, there is an option to have a TI min and max for the patient triggered breaths. So it's important to understand whether you need to make adjustments in that TI min or that TI max to affect that IDE ratio. So that's kind of a systematic approach to how I go about trying to interpret data downloads. But again, nothing's as good as being able to actually look at cases. And so I put together some case examples that might give you a sense of how I might approach it, but then also some of the data that you get. So these are all patients of mine that I've seen in clinic. So this one is an 82-year-old female with kyphosis, bronchiectasis. She is on a Trilogy Evo for chronic respiratory failure with settings as below. She's in ST AVAPS with a tidal volume of 440, an EPAP of 6, an IPAP min of 20, IPAP max of 24, a respiratory rate of 18, I time of 1.3, a rise of 3, and then she has a TI min and max setting of 1 second and 1.7 seconds respectively. And so this is some of her data that's really the average data over time period. I believe this might be about 30 days or so. And so some of the data that we're looking at from top left to right, you see the average peak inspiratory pressure of 18.8, so that's still within the range of what the targets are. She's on a fixed EPAP of 6. So she's breathing at about 19.2 breaths per minute with 41.9% triggered breaths. So that means that 42% of the time she's triggering the breath, whereas about 58% of the time the machine is triggering the breaths. So 58% of the time she'll get that set inspiratory time of 1.3. Otherwise, it's going to be somewhere between that 1 to 1.7 range. Her target average tidal volume exhaled is right about on target. So this I'm very happy with. If we look at the second line, her I to E ratio is 1 to 1.43. So I'm happy with that because she has a lot of restrictive physiology from her kyphosis. And again, she's using it every day for about, I bet, about 9 hours a day. And then here, as I'm looking at her leak, her total leak is 45.6 and her unintentional leak is 15.3. So overall, that's acceptable to me. So to me, she's doing really well on her non-invasive ventilation. And since she's doing well, I don't want to rock the boat, and I've kept things as they are. This is a schematic of some of the data through the night. So you can see that her pressure stays relatively stable throughout the night. And then you can see that there are times when her tidal volume does fluctuate, but for a lot of the time between, say, midnight and 6 a.m., her tidal volume delivery seems to be right on target. So again, this tells you a little bit about that granular data that you're able to actually use to interpret what may be happening through the night, particularly if they have certain complaints. So case example number 2, this is a 69-year-old male with COPD, obesity, OSA, on a Trilogy Evo for chronic respiratory failure, and he's on the following settings. He's on an ST AVAPS with tidal volume of 600, an IPAP min and max of 20 and 30, an EPAP of 10, respiratory rate of 14, I time of 1.3, rise of 3, and a TI min and max of 1.2 and 1.6. What you can see here, his tidal volume target is 600, but you see here on the right that his exhaled volume is only 524. And as I'm thinking through how do I troubleshoot that, first thing that I want to do is actually look at the leak. And you can see here that his total leak is 97.4 and his unintentional leak is 63. So really, this is someone where even all the other data not going to be as reliable. So it's important to first troubleshoot that. And so we've really worked on different mask types, trying to shave his beard. So if you see this, you really want to stop there and see what you can do with the interface, particularly in that setting of a very large average unintentional leak. So again, tidal volume here, leak, and the unintentional leak are data that you really want to look at. So case example number 3. This is a 92-year-old male with diaphragm paralysis. He's had a long hospital course and then was prescribed a ResMed air curve, which he uses about 15 hours a day, overnight, and intermittently throughout the day because he has such weak diaphragm. And after he was discharged from the hospital several years ago, he was set on this spontaneous mode of bilevel with an IPAP of 16 and an EPAP of 7. And so looking at this data download, you see that, his usage is great. The leak is generally tolerable. He's in this fixed bilevel mode. AHI is a little bit higher than we would expect, but generally tolerable. But I want to highlight a couple of different setting or output from the device. One is that we see this median tidal volume delivery of only 287. And then we also see that his median respiratory rate is 23. So again, a little bit more of this rapid shallow breathing type pattern, which is again not unexpected given his underlying diaphragm paralysis. And so he came to see me in clinic. I ended up switching him to an AirCurve 10 STA. So this is a mode with a volume assured pressure support called IVAPS, where we target alveolar ventilation. And I kept a lot of his settings the same. I kept his EPAP the same. I targeted a minimum pressure support of 10, which is an IPAP minimum of 17, which is close to what he was on before. And then I put a little bit of a larger range so that the machine could adjust to try to maintain this target alveolar ventilation. I had a target rate of 16. And one of the things to note is that on this device, I set a TI min of 1.2 with the goal of trying to slow down his respiratory rate because of his diaphragm paralysis. I wanted to give enough time for that pressure to be delivered. And what you can see here, again, getting relatively similar pressures, is that his tidal volume delivery was able to be increased to 445, and his average respiratory rate went down to 16. And so it's important to look at this percentage of triggered breaths, which is down to 50%. So not only is he riding the backup rate, but this spontaneous breath cycled of 11% means that for 88 or 89% of the time, he's getting that inspiratory time of 1.2. So as you're interpreting data, it's really important to understand what the role of inspiratory time is on both lung mechanics, tidal volume delivery, but you can see that that really changed his breathing pattern from this rapid shallow breathing pattern to a slower, bigger tidal volume breathing pattern. And then for a last case, there's this 75-year-old female with kyphoscoliosis. She's on a Breas, sorry, there's a typo there, but on a Breas Vivo 45 LS for chronic respiratory failure with the following settings. She is set in a pressure support with target volume, a PEEP of 4, rise of 3, inspiratory trigger of 2, expiratory trigger of 7, target volume of 450, a minimum pressure of 14, a maximum pressure of 24, and again, there's this TI min and max of 1.1 to 1.6 for the patient-triggered breaths, and then for the machine-triggered breaths, you have a backup rate of 16 with an inspiratory time of 1.3. And so, again, this is average usage where the target volume seems to be right at target, the leak seems to be tolerable, and then the average peak inspiratory pressure is 20, which is, again, within the range. And again, we're looking at usage, the compliance, and then again, the AHI is a little bit high, so there may be some adjustments that I want to make over time. But this is a new vent initiation, and so we're really trying to just get her used to it over time. But again, this is average data. And then if you look at more granular data, you can see what happens throughout the course of days. And then you can also look at an individual day and look at what's happening hourly. So this is really kind of the future of interpreting data downloads. It's not as straightforward and as simple as getting these averages that we used to get from the SD cards. And so again, if you're starting to see more and more patients on non-invasive ventilation and you want to most effectively manage their ventilation over time, it's important to get familiar with these data downloads, create a systematic approach that will really help both with synchrony usage, but then again, hopefully maximizing ventilation as well. So again, in summary, understanding how to interpret ventilator downloads is really important for optimizing ventilator settings, and this will have repercussions in terms of usage, compliance, all the things that are important to improve patient outcomes. Understanding the modes of ventilation is an important starting point for interpreting data downloads, so I would recommend going back to some of those fundamentals and listening to some lectures on modes of ventilation. And then again, creating a systematic approach to the data makes interpretation a little less intimidating. I know it can be feel very chaotic and intimidating to look at all that data, particularly if you don't have much experience doing that. But again, if you go through it stepwise, I think that will help really understand how to make sense of all this complex data that can really help your patients in the long run. And so again, this is meant to really be an overview of data downloads, so it's really important to get more and more practice, but feel free to reach out if you have any questions regarding this webinar.